Good afternoon. I'm Roger Blumenthal, Professor of Medicine here at Johns Hopkins, and I'm here with my colleague and good friend, Dr. Peter Kwiterovich, who's Director of the University Lipid Clinic and really the Dean of atherosclerosis and lipid disorders. Peter, what we're here to talk about over the next 45 minutes or so is management of residual cardiovascular risk as it relates to lipids and lipoproteins. And
a normal ratio of LDL cholesterol to ApoB was like 1.2 to 1.4 in adults, and as the ratio got less and less, lower and lower than 1.2, and as it approached 1, then the ratio of LDL cholesterol to ApoB, then that was an indicator that you had an increased number of particles, and they were small and dense, but increase the number is the important thing. So let's say your LDL cholesterol was 130 and your ApoB was 130, then they have an increased number of small dense LDL particles.
Welcome to CardioCareLive again.
Thank you. I view Tony Gatto as the true dean of the life protein field. Well, I don't mind being an associate dean.
Well, Tony's the dean of my alma mater, Cornell Medical College, and we can we'll give you the title of associate dean. But than Peter to help guide us through this. Just recently, a lot of us received notification by email and then by mail that the FDA not only has had strong concerns about simvastatin 80 milligrams, but now even 40 milligrams when used with a calcium channel blocker. And I think there'll be pharmacies warning us to not go above Simva 20 milligrams, Peter, when people are on a calcium channel blocker. And this will, I think, directly affect the prescribing habits quite a bit. One of the first questions that's already popped up, and I encourage the audience to keep emailing questions, is aside from a person with familial hypercholesterolemia, what's the youngest young adult that you might consider therapy in whose LDL is, let's say, less than 160? Do you feel that Jupiter gives us good data to start therapy sooner rather than later? What's your approach with statins in young people?
Right. Well, of course, to get into Jupiter, you had to have an elevation in highly sensitive C-reactive protein, and I think that many of those folks either had, predilection to diabetes or had the metabolic syndrome. So, in a healthy younger person, I wouldn't expect that to be the case. I pay a lot of attention to the family history, and even if I think that it's not familial hypercholesterolemia, if there's a lot of premature disease, then I will be much more aggressive in younger people, including young adults. The cut point for that is below 160. It's perhaps hard to decide when you might do that. I might measure the ApoB, and if it was above 120, then I probably would start them on medication if they had a bad family history of premature disease.
One question already, another question that came in about ApoB. Is it most cost-effective to just check an ApoB when the triglycerides are above a certain level, say 130 or 100, or what is your recommendation to practitioners about when to use ApoB?
Right. Well, ideally, I think ApoB should be measured as part of every lipid profile. The reason for that being is there can be a big disconnect between the LDL cholesterol value and the ApoB value. And so even in some patients that have a relatively mild hypertriglyceridemia, they might have a lot more LDL particles than meets the eye. And if there is this disconnect with the ApoB seems to be elevated out of proportion to the LDL cholesterol, then you know, it indicates that probably they are at high risk. We published a paper a long time ago, about 3 decades ago, with Alan Steinerman, and we looked at patients that had coronary artery disease and not coronary artery disease, and then we looked at triglycerides and ApoB. What we found was if the hypertriglyceridemia was, let's say, 700 or 800, most of the time the ApoB was low, so they really had more of a familial hypertriglyceridemia and not a huge increase in the number of LDL particles. On the other hand, those who had triglycerides between 200 and 500 with coronary disease tended to have very elevated ApoB and an increased number of total LDL particles. So I think it's it's good to try to estimate or determine whether there are more LDL particles there than you think, or perhaps less. So, I mean, some people might say, well, triglyceride is 600, 700, I'm going to treat them with a statin. Well, that may not be necessary. That may be primarily a triglyceride problem.
So before we get into combination lipid-lowering therapy, Dr. Diaz wanted your opinion about how do you use the ApoB to determine who has small, dense LDL particles, so you don't have to do perhaps some of the VAP testing or with Atherotech or liposcience. Is there any sort of ratios you use, and when do you think ApoB is high enough that it would signify a higher risk?
Well, when we did our original studies,
So we've already started getting comments, Peter, about how important combination therapy is in light of a couple important studies that we'll talk about. One is ACCORD, one is AIM-HIGH. So I guess to review with ACCORD, this was diabetics, average triglyceride around 160. Everyone was on simvastatin, started off at 20 and then titrated up to 40 for most of the people later on. And what we found was that fenofibrate didn't lower overall events, much to our surprise. And there was a trend for worse events in women, but overall, I guess if the LDL, if the HDL was less than 35 and the triglycerides were above 200, there seemed to be a trend for benefit. Tell us how you put ACCORD into the equation about when to add fenofibrate or some other type of fibrate.
Well, I think a critical component of performing a randomized placebo-controlled trial is to make sure that your population is reasonably homogeneous. It's never going to be perfect, but we've seen examples of, you know, there is no effect, but then if you stratify, there is an effect. Now, of course, if you don't find a significant effect for the overall population, statistically, you're not supposed to do these subgroup analyses. But in the Helsinki heart study, for example, which was a primary heart study of patients that tended to have higher LDLs, higher triglycerides, and low HDLs, gemfibrozil produced a significant reduction in cardiovascular events. And actually, there weren't that many diabetics in that study, but when they did look at the diabetics, even though they were small in number, they had a beneficial effect of gemfibrozil. So I'm not sure, why the fenofibrate was not more effective. I can't think of a molecular reason why gemfibrozil would work and fenofibrate would not work. So it may be that if your triglycerides are higher, that you get more of an effect with a fibrate, and of course they're designed to be, a triglyceride-lowering drug, and so that's the only explanation that I can really come up with.
So many of us had just sort of assumed that with these patients with an average triglyceride of 160, they had smaller, denser particles, and there's been such a push to do the advanced lipoprotein testing to identify pattern B, yet we didn't find a benefit. Some people have speculated that maybe gemfibrozil works and fenofibrate doesn't seem to work as well. Can you go over why we don't prescribe gemfibrozil now and its potential interactions with statins?
Yeah, I think if one looks at the metabolism of gemfibrozil and the metabolism of fenofibrate, gemfibrozil is more involved in terms of the degradative pathways with the statins than the fenofibrate. So it does tend to interfere more with the catabolism of the statins compared to the fenofibrate. And this is borne out clinically, where there does seem to be a greater incidence of myopathy and myalgia and rhabdomyolysis with gemfibrozil than with fenofibrate.
So fenofibrate is generic, I believe, for the most part?
Yeah, it's fairly easy to prescribe fenofibrate generically, yeah.
And fenofibric acid is the newest brand name. And one of our listeners has already asked your opinion about, is there any potential reason why fenofibric acid, the brand name, might be better than fenofibrate, and which one do you usually pick at the Johns Hopkins Center for Lipid Disorders?
Yeah, well, I think the the newer agent, there's an initial step in the metabolism of the fibric acid derivative, and the newer agents, you don't need that step to make it into an active metabolite. It's already an active metabolite. So theoretically, it may get there quicker than the old fibric acid derivatives, but I really don't use that as a reason to prescribe one versus the other. I think that they probably both lower triglycerides about the same extent.
Is the typical dose of generic fenofibrate 145 milligrams, or is it 160 milligrams?
Well, your Tricor is 145, and then the generic, there is a 160 generic, and I believe there's also a 135.
Okay. So one of our viewers indicated that they think it's fine to use a fibrate if the triglycerides are greater than 200, but what about the potential for decreasing microvascular events? In your view of the literature, do fibrates do that, and even if they don't decrease cardiovascular events over a 5-year period, do you feel that the data about microvascular events is strong?
Yeah, well, I must admit I don't use them for that particular purpose. I mean, do you?
I haven't, and so I've tended to, I think most cardiologists have sort of looked at Accord as a way to say, well, we don't need to go to combination therapy quite as much. Mm-hmm. But we do have data that these people seem to be at higher risk, more smaller, denser particles. They tend to have higher ApoBs, and at least over the 5-year period of Accord, we didn't see a benefit. So that was disappointing. And I guess it may remind us that the lipids are an important part, but there's other factors too that can determine events in diabetics.
Sure.
So the next set of questions that have come in deal with niacin and AIM-HIGH, and you were the principal investigator for the Hopkins AIM-HIGH site. I guess approximately about 3,500 patients total worldwide, and mean LDL of 71, and that was before people got randomized to extended release niacin versus placebo. Is that correct?
Yes.
And tell us what your thoughts were of the null result and any caveats that you might have about AIM High.
Well, I think, the data are the data, and there was no significant difference between the Simva and niaspan group versus Simva and placebo. I think, there were several factors in that study that need to be considered. One was the nature of the study population. I think the average age was 67 or 68. Many of them didn't just have coronary disease, but they could get into the study if they had cerebral vascular disease or peripheral vascular disease. So it was a mixture of, I think, more severely affected older patients. The second confounding factor is this great push to get the LDL down, essentially as low as possible.
Right.
And which I think ideally is the goal. But in your patients and my patients, many of our patients, we can't get the LDL down to 70 or 60,
right.
And we're stuck. We're happy if we get it less than 100. So I think the patients that the viewers see, and a lot of you and I see in our clinics, probably reflect the need for combination therapy to try to optimize their lipid profile. And I think that's a different group than the group that was studied in AIM High. I'm still taken by the data from Greg Brown from Seattle, because it's pretty powerful, even though the total number of patients is not that high. But it certainly seemed in those studies that niacin plus a statin was an excellent choice.
And I guess there's angiographic study HATS, which also had a decrease in clinical events. There, they used the niacin in combination with a statin versus placebo. It didn't look at the niacin added on, but these original angiographic studies, as you point out, did, I guess for the most part, look at niacin plus a resin, and showed decreases in improvements in coronary artery diameter as well as in events. But I guess our viewership here seems to be a little bit more cynical about these results. I guess my opinion was that I'll still use niacin to help lower that LDL down further, and I guess I'll look at those patients with higher Lp(a) whose LDL isn't down to 70. But while I was much more inclined in the patients that we declined enrollment in AIM High to use niacin in people with HDLs less than 40, especially if they had coronary disease or a strong family history, I'm not going to do that now. I guess we'll present some subgroup analyses of people with the high Lp(a) to see if they had any potential benefit. Is that correct?
Yeah, I think there'll be a series of analyses that will be performed, including looking at the number of LDL particles and whether they're small and dense. From a theoretical standpoint, I agree that if the LDL is sufficiently low, that the HDL assumes less importance. Okay. So if you look at the Tarahumara Indians that are hunters and gatherers, 85% carbohydrate, their LDL cholesterol is 60 and their HDL is 35. Triglycerides on average 120, they don't get coronary disease. Right. But in our society, our average LDL is not 60. Average LDL in adults is 130, so that means half of them are above 130. And so under that scenario, looking at the population from that standpoint, because the LDL is so high, it appears, based on epidemiologic studies, that HDL does have an effect. And I think that the way I view it is that as long as that LDL is not at goal, then you know, the HDL may have some importance in terms of predicting, you know, recurrent coronary events. And in the TNT study of 80 of atorva versus 10 of atorva, you know, they presented the data that if the group was in the lower fifth quintile for HDL compared to the upper fifth quintile, that was an independent predictor of, you know, recurrent events. And that low HDL was accompanied by, which the mean was 37, by an average triglyceride of 160, and the ApoB, the average ApoB was 116, which was close to elevated at 120. So I think it's those types of interactions that that are important. And but if we could get the LDL down to 40 or 50 with a statin alone, you know, probably we wouldn't need a lot of additional agents, unless the triglyceride was high enough to be of concern.
To clarify things, before the niacin was added, how many people needed to, or approximately, do you know what percentage of people needed to get ezetimibe added on to the simvastatin? Were they trying to get everybody, I guess, to an LDL less than 80? And then if they couldn't get that, then the ezetimibe was added on? Yeah,
there were, and the exact numbers, I think there are like 500 or 600 people that were on ezetimibe.
Okay.
Out of the 3,500. So, yeah, the way I view it is that the trial was designed to see if HDL raising had an independent effect. But I feel this is a little bit naive because niacin has a pleiotropic effect. So not just raises HDL, lowers triglycerides, it lowers the number of LDL particles, it decreases HDL catabolism, and so all those things appear beneficial. So,
right. Yeah, as another viewer said, it didn't work.
Yeah.
One person sort of scolded us, Peter, for not mentioning the numerically the higher number of strokes.
Right.
Maybe you could give us your opinion about that, and do you think that's just background noise, or we really don't know?
Right, well, the initial analysis of the stroke victims and the people on the treatment group had a higher prevalence of ischemic strokes than the people that were the people in the placebo group. And it turns out that a significant proportion of those in the treatment group who did develop ischemic strokes had been discontinued from the niacin for quite a while. And so the question is therefore raised. Right. You stop the niacin because they couldn't tolerate it, and they still get ischemic strokes. Is that due to the niacin or not? So I think that's the issue, that in a number of those patients, it may not have been due to the niacin. And you know, in the Coronary Drug Project, niacin decreased heart attack and stroke. So right. I don't think there's anything inherent in niacin to promote ischemic stroke. I just don't think the previous data support that at all.
So let's switch gears to the HPS2 Thrive, because that's continuing. And one of our listeners pointed out that they were puzzled that there's so many more patients, subjects enrolled in HPS2 Thrive. And my understanding is that it wasn't restricted to the metabolic syndrome focus, so they have a much broader group of lipid profiles. And I guess it's reassuring that that hasn't been stopped for any harm. And hopefully we'll see some benefit there. But they use laropiprant, I guess a prostaglandin inhibitor, to decrease flushing. Any insights or comments about doing that to decrease flushing? And do you have any insights about when that study will be finished?
I think that study should be completed in about 2 or 3 years, especially with a huge sample size. Mm-hmm. But I think it's a very well-designed study and incorporates the kind of patient that I've been talking about before, which is, you know, the thing that we ordinarily see in the practice of medicine, or we see in the lipid clinic. And so I think that the patients will be more representative of what we ordinarily deal with, and if that study is negative, then I guess I'll have to say uncle.
Well, Dr. Bussa emailed in to get your thoughts on a middle-aged individual whose LDL is less than 100, but whose HDL is less than 40. And let's say some family history of heart disease. Are you less inclined now to add niacin, or if, let's say, there's a couple risk factors and this middle-aged individual is at close to 10% 10-year risk, is your thought to, right now, if you're going to do anything, to use a statin to lower that LDL further rather than niacin? How do you think you'll deal with this in the low HDL patient?
What dose of niacin, what dose of the statin is the patient on?
Well, I think he's referring to initially a primary prevention, asymptomatic person. What would be your first step in someone whose HDL is less than 40?
Is he starting with an LDL of 100?
Starting with an LDL of 100, but the HDL, let's say, is 35. This person has a family history of heart disease and maybe one other risk factor. Well, I guess in the past, this particular doctor was more inclined to use niacin to raise the HDL, and was wondering your opinion about if they're going to do something, should they just try to lower the LDL?
Well, first of all, in that kind of patient, I would assess whether there's a disconnect between the total number of LDL particles and the LDL cholesterol. You can have an LDL cholesterol of 90 and have 2,000 or 2,500 nanomoles of LDL present, or you could have an ApoB of 120, 130. So if you document that you really do have an increased number of LDL particles, then definitely the focus should be on the statin, and I probably would start with a statin. Even if I didn't have those data, I probably would start with a statin.
Okay.
And then I would reevaluate it. The statins will increase HDL to a certain extent, and if the patient loses weight and exercises, it might bring it up some more. So I wouldn't start with niacin. I would start with a statin. Agreed.
So now we have a flurry of questions dealing with ezetimibe. And I guess some people have viewed the recent SHARP study in individuals with chronic kidney disease or dialysis as a big win for ezetimibe, because prior studies with atorvastatin and rosuvastatin in dialysis patients did not show convincing cardiovascular benefit. Maybe you could summarize your thoughts about the SHARP study and how you view ezetimibe now.
Right. Well, I think that when the results were presented, the nephrologists were ecstatic, because they had been very frustrated over the years to try to prevent atherosclerosis in their patients with chronic renal failure. So this was, a hope to them that maybe this combination would actually, decrease coronary events, as the study indicated. I don't know what effect ezetimibe had by itself in these patients. And the study really wasn't designed to answer that. In other words, there wasn't an ezetimibe group by themselves. I think the fact that there wasn't any harm was very useful as well. I think that some of the previous studies that have suggested ezetimibe might have dangerous effects or probably not right on. I think if you look at a lot of those studies, there's problems with the study design and et cetera, But I think that there are several studies now with ezetimibe. And I think in the heart protection study, isn't one of the groups ezetimibe in that as well? I'm trying to remember.
Well, they don't have ezetimibe, I don't think, in the HPS2 Thrive. But I guess the main ezetimibe study is still, we're waiting for the IMPROVE-IT in the acute coronary syndromes.
Right.
One of our viewers reminds me of the controversy we had, I guess, a year and a half ago with the Arbiter 6 HALT study, where the investigators there suggested that the greater LDL reduction you had with ezetimibe, you got modest worsening of IMT, but the greater the benefits in terms of HDL, you got a more improvement in IMT. Now we have a study that suggests that niacin added on to a statin, just like they did in Arbiter 6, if anything, there's a few more events in that niacin group, and they want our opinion about serial carotid IMT studies, and are they really necessary for new lipid-lowering agents? What are your thoughts about the carotid IMT studies, and do we really need those types of studies in the future?
Well, this is just my opinion. I think that the carotid IMT can be sort of an interesting tool to look at particular groups of patients, maybe to assess in a preliminary fashion the effect of certain drugs on carotid IMT, but that really we need the hard endpoints in the end, and so that that's how I view it. I don't do carotid IMT in my patients from the lipid clinic. I do try to assess, whether I think they have clinically significant carotid stenosis, but I don't systematically do carotid IMT, and I wouldn't recommend it.
So another person asks about in younger patients, middle-aged patients with, say, one other risk factor in borderline dyslipidemia, do you ever use a coronary calcium scan as a tiebreaker? If someone had no coronary calcium, would you say that we can defer therapy, and if they had above average for their age, are you more apt to treat them?
Right. Well, I think that's more your bailiwick. I know you have a lot of interest in this. I have used it, especially in patients where I'm not sure of how much risk they may be. I had a 37-year-old woman with a completely normal lip lipoprotein profile. Her father had a lot of premature disease and an elevated LPA. I checked the LPA in her, and it was very elevated. And so I asked myself the question, what should I do? The LDL is like 120, 130. So I got a coronary calcium score, and it was over 200 in a 37-year-old woman. So that was pretty clear to me that, that woman actually had to be treated with medication. So I try to use it when I'm not sure, whether to treat with medication. I try to make sure that there's a clinical action that will result from actually doing the test. I don't know, how do you approach it?
So often, I think if they don't qualify right now for lipid-lowering therapy, I usually show them what their Framingham score will be 5 years later or 10 years later, where they will qualify. And I say that we need to decide if you want to start earlier to slow the progression of disease. Even if you have no coronary calcium, you still may be developing some non-calcified plaque. Many times patients will be reluctant to go on a medicine, and they really want proof, and I think a high coronary calcium score can certainly be more motivation for them to stick with a statin. But I worry sometimes that when we do get the no or minimal coronary calcium, people may get a false sense of security. And we also have to keep in mind the limitations that 5 to 10% of people who get the coronary calcium scans will have an incidental finding. The radiologist will want to get a follow-up CT scan, often for lung nodules, to see document stability at 6 to 12 months, and that can also raise some angst and anxiety among our patients. So it's a challenge, but I think subclinical atherosclerosis testing can be a tiebreaker. A number of people, Peter, want us to comment a little bit on resins and what your thought is the data with colesevelam about improving glycemic control and lowering A1C, and how you decide whether you would use a resin versus ezetimibe versus niacin as your add-on therapy?
Right. Well, I think that the ezetimibe will lower LDL cholesterol about 15 to 20%, and so do the sequestrants, and so do niacin. So if you want to choose a drug that's going to lower LDL, all three of those lower LDL to about the same extent. Niacin has an additional effect on HDL and triglyceride. Ezetimibe is primarily for LDL. Sometimes you get a marked decrease in triglyceride. The bile acid sequestrants, if they tend to have hypertriglyceridemia, the triglycerides may go up. However, with time, it seems to come back down. I suppose one could, make the case that if you had somebody with tendency towards hyperglycemia and you needed a 15% reduction in LDL over and above a statin, that might be a reason to choose it. Sequestrants are a very good class of drugs, and we showed in the Lipid Research Clinic's coronary prevention trial that use of bile acid sequestrants will decrease coronary events in healthy men with high LDL levels. So I think they do lower risk for coronary disease.
So when you use colesevelam, are you typically using the tablets, or now I believe there's a powder that you can dissolve? Mm-hmm. What do you find that patients seem to prefer more?
Well, I've primarily used the tablets, mm-hmm. and the tablets you can actually take 6 tablets at one time. Let's say with lunch, if you and it will be just as effective as if you do it in divided doses. I do know that for young patients, the pediatric patients, that there's actually a liquid formulation that's available to help them if they have difficulty, swallowing the tablets.
So, Dr. Glasser writes in that a number of years ago he recalls you put a lot of stock in the total cholesterol HDL ratio, and he's concerned that some insurance companies in Connecticut and Medicare doesn't cover ApoB. What's the approximate cost of ApoB for the patient, and is ratio still something that doctors should look at when trying to decide whether to treat?
Mm-hmm. Well, I think that historically the ratio of total cholesterol to HDL was a pretty good indicator of risk for coronary disease. It's not perfect. The ApoB measurement used to be very economical. You could get it for $10 or $15, and now, some labs charge $60, which I personally think is a ripoff. They use they do the ApoB, in an automated fashion, immunoprecipitation, nephelometry, and so why do they have to charge so much? So if the patient doesn't have insurance, then you may not want to do the ApoB if they can't afford to pay for it. The alternative is the NMR lipoprofile, which will give you the total number of LDL particles as well. And when you put the lipid profile together with ApoB, it begins to get more pricier, and so.
So Dr. Felgen writes in that ApoB the cost for that from Quest Lab was about $100. While an NMR cost about $75 from LabCorp, and she wanted to find out, or he wanted to find out, if that's typical. My patients, I think, also had told me that when I ordered ApoB, it was $25 to $50, so $100 seems awfully high.
Yeah, I think it's around $60 or $65. I don't have all the details. Sure. Because I try to do what I think is, indicated for the patient, and there is a societal issue of having to pay too much for tests,
right? And
but yeah, that was one of my points about the lipoprofile and the NMR, was that it may be cheaper than doing lipid profile plus an ApoB or whatever, they may add up to
Sure.
to greater than that. So I think these cost considerations, can be important. And
so with the NMR from LipoScience, the LDL particle number is really what they focus in on. And would you say that a good target for your higher risk patients is less than 1,000? Sort of the bottom quintile, is that sort of the number that sticks out with you?
Yeah, 1,000 is less than 1,000 is the pie in the sky.
Mm-hmm.
The average is about 1,400 nanomoles per liter, and once you get up to 1,600, it's pretty high, pretty elevated, and 1,800 is very elevated, about the 90th percentile. So yeah, a goal of less than 1,000 is that's ideal, I think.
So Dr. Felgen wants you to check with Quest, Peter, because Dr. Felgen says that just looked it up in the current Quest catalog, and the ApoB price is $103. Dr. Felgen couldn't believe it, but that's what it says. So she or he, I'm not sure if Leslie's a male or female, thinks that you need to straighten out Quest because it shouldn't cost nearly that much.
Yeah, I don't know what. Perhaps you could find out how much LabCorp charges and let us know before we finish.
So a number of people also expressed the view that that maybe we don't need anything else other than ApoB and the lipid panel. What other information do you sometimes find useful when you get the LipoScience test or the Atherotech tests in their advanced lipoprotein studies? Is there anything there that the practicing cardiologist or internist really needs to know if you have the ApoB?
Right. Well, a patient comes into the lipid clinic and they have an elevated total number of LDL particles. Now, if you assess the number of small LDL particles, it gives you insight into the pathophysiology of the elevated LDL particle number. So, for example, in familial hypercholesterolemia, they're almost all regular size or large particles. So if your total LDL particle number is 3,000, the small dense LDL particles will be 500 or 600. On the other hand, if they have familial combined hyperlipidemia, the overproduction syndrome, their total number of LDL particles is 2,500, and over 50% of that is small dense LDL, between 1,500 and 2,000. They're really producing a lot of VLDL particles. And from the Framingham Heart Study, for small dense LDL particles, 800 was the 90th percentile. So it tells me, it helps me to say, that the people with VLDL overproduction, they're more likely to require more than one medication, because the statins do remove or improve the number of small dense LDL particles, but then you still have the residual overproduction that's going on. The statins will also affect that to a certain extent, particularly in higher doses of more potent statins. But it just gives me insight into why they have an increased number of LDL particles. And so that's what I find attractive about it.
So another viewer wants to know what your goals are for ApoB. I guess the ADA and the ACC published a paper shortly after the review that you and I and other members of cardiology did in JACC, and they came up with an ApoB target for people with the cardiometabolic syndrome of 90 for primary prevention and for 80 for secondary prevention. Is that sort of your thought, or how do you decide how low to go in terms of ApoB? Assuming it's not $103.
Yeah, I don't agree with those recommendations. If one looks at LDL cholesterol of 70, that's about the second or third percentile. And to get an ApoB in the same area is down to 60.
60, right.
So 80 is still 25 to 30th percentile, whereas the LDL cholesterol is way down, you haven't done as good a job as you should to reduce the number of LDL particles. And the same thing happens with statin therapy. The LDL cholesterol comes down to a lower percentile than the ApoB. So I would like to see ApoB at 60. Then I know we wouldn't have any coronary disease.
So as we wind up here, do you think the future is more and more middle-aged adults will go on a generic statin and just try to use an LDL cholesterol of less than 100 as another vital sign like blood pressure? Or do you think that, as you mentioned before with Jupiter, they only really looked at men over 50, women over 60, and the median age was 66? Are we jumping the gun about putting people with low Framingham risk scores who are, say, 50 and above on statins?
Yeah, I think that's an excellent question. Conceptually, we know that for each 1% reduction in LDL cholesterol, you get at least a 1%, possibly 2% reduction in coronary events. So on a population basis, if you bring the average LDL down, even a relatively small amount, you prevent a lot of coronary events. So that would be, one argument that we would use statins to a greater extent. Even though you're going to be treating a larger number of people that aren't going to get disease, but you're going to decrease the burden of events in the general population. And I don't think that, from a clinical standpoint, we really have the data to say that, we should do this. But I suppose if they took 100,000 people in middle age with Framingham risk score of 10% or lower and treated half of them with a statin and half with placebo, that, those on the statin are going to have a reduction in events.
Right.
So
final quick point, just have 30 seconds to go. Omega-3 fatty acid supplements, when do you prescribe them as opposed to niacin or fibrate?
Well, I think omega-3 fatty acids can be, a very useful adjunct to treatment. In adults, they'll lower the triglyceride mean of about 50%. And so they might bring the triglyceride down from 1,000 to 500. In Europe, the use of fish oils has sort of gone beyond that. They find that the use of omega-3 fatty acids decreases sudden death, but not the myocardial infarction rate. But if you have an MI, you're less likely to die. So there may also be a role, and you may want to comment on this, that patients that, with coronary disease, should they be on 1 gram of fish oil a day? And so, I think they're a useful adjunct to our armamentarium, particularly in people that may not be able to tolerate fibrates, for example. Or you may want to try them together if you're really concerned about your patient.
Right. I think it's a challenge. We've been faced with all these studies that have been disappointing recently, AIM High, Accord. Hopefully we'll see some more conclusive studies with omega-3 fatty acids in the modern era. But I just wanted to thank you, Peter, for a great discussion on the management of residual cardiovascular risk. And I want to remind people to do the post-test questions for CME credit. And thank you very much for your attention.